Good afternoon, everyone. For those who don't know me, my name is Louise. My pronouns are she and her, and I'm a clinical fellow in pediatric hematology oncology here at McMaster. I'm also completing graduate studies in clinical epidemiology through the clinician investigator program here. The title of my project is As You've Said, and I'm very grateful for my supervisors on this project, Dr. Ronald Barr and Dr. Lehana Tabani, for their support and encouragement. There we go. I'll start with some context. So pediatric acute lymphoblastic leukemia, or ALL, as I'll shorten it throughout the presentation, is one of the most common childhood cancers, representing about a quarter of all cancers that we see. With modern therapy, it's also exceedingly curable, with greater than 85% chance of cure for all of those diagnosed, and a much higher number in the lower risk groups. However, survivors of childhood cancer do not all escape unscathed, and many of them are at increased risk of late effects from their therapy, which includes an increased rate of metabolic and cardiovascular disease relative to their age-matched peers, as you can see here. It is increasingly evident that treatment-related body composition changes can persist for years in childhood cancer survivors and are likely contributing to some of this increased risk. Some of the main changes that happen are a loss of lean muscle mass, which is known as sarcopenia, and an increase in fat mass or increased adiposity. When these changes occur together, we call it sarcopenic obesity. Both sarcopenia and increased adiposity contribute to the development of poor cardiovascular health, frailty, and poor quality of life. Together, this predisposes childhood cancer survivors to increased morbidity and mortality at a younger age compared to the general population. Unfortunately, predicting those who are most at risk isn't always easy. We know that some things like radiation and high amounts of steroid use certainly increases the risk for obesity and its associated metabolic risk. However, other elements of treatment likely influence body composition changes in a multifactorial manner. Ideally, we would like to screen for sarcopenic obesity in survivors, allowing for early intervention and prevention of complications. There are many ways to assess body composition, ranging from simple clinical indexes like the body mass index, which you can see here at the top of the triangle, and similar indexes like the Triponderal mass index, which is a newer index just popularized in the last few years and adjusts the weight for height cubed rather than squared. And this is things at the top of the pyramid compared to things at the bottom, which were much more in-depth assessments and more complicated measurements, such as MRI or dual energy X-ray absorptiometry, which is abbreviated as DEXA scans. There's typically a trade-off, as you can see on this triangle, between accuracy and ease of use. So things at the top are super easy to use, but things at the bottom are much, much more accurate. In most folks that are not childhood cancer survivors or cancer survivors in general, BMI is an adequate but imperfect tool for predicting high amounts of fat. However, its use in childhood cancer survivors who are predisposed to sarcopenic obesity has not been validated, and a normal value of BMI may actually provide artificial reassurance in the presence of sarcopenic obesity. So our research question for this project primarily is aimed at exploring whether tools used commonly in clinical practice, like the BMI or the TMI, are able to detect the presence of sarcopenic obesity as defined by DEXA scans, which is considered a gold standard measure of body composition measurement. We've evaluated both the BMI and TMI, as there's some evidence to suggest that TMI is a better index for evaluating adiposity, particularly in adolescent and young adult populations. This project is a secondary data analysis of a previously performed cross-sectional cohort study. The original cohort consists of 75 long-term survivors of pediatric ALL treated here at McMaster. In this study, extensive body composition assessment was done using anthropomorphic measurements and DEXA scans, which provided detailed data on proportions of fat and lean mass in survivors. Using this output, a number of indices can be calculated. For example, the fat mass index is the fat mass adjusted for height squared. These patients were classified as having sarcopenic obesity if they had both an elevated fat mass index and a decreased appendicular lean mass index, which is a measure of skeletal muscle mass, compared to population norms. Our analysis on this project is analogous to evaluating the effectiveness of screening tests. We are interested in whether BMI and TMI at various thresholds could be used to screen for sarcopenic obesity. We picked BMI and TMI thresholds, which are described here at the bottom, with clinical correlation to obesity and overweight status, as well as a TMI threshold associated with development of metabolic complications in youth. We also performed some simple regression and correlation testing to see if BMI or TMI was associated with measures of body composition in this survivor population. Overall, our results indicate that BMI and TMI are ineffective screening tests for sarcopenic obesity. At thresholds associated with obesity and overweight status, both sensitivity and specificity were less than 50%, and total misclassification rates were high. We did note that using a highly sensitive screening threshold for TMI picked up all patients with sarcopenic obesity, but the specificity at that threshold was only 14.6%. Our correlation analysis suggests that TMI is more strongly correlated with adiposity in this survivor population than BMI is, which is similar to findings in healthy populations, though adjusting for sex narrows this gap. We also noted that BMI has similar correlation between fat mass index and fat-free mass index, which highlights the inability for BMI to distinguish between adipose and non-adipose tissue. In summary, our exploratory analysis confirms that BMI and TMI lack sufficient predictive accuracy to be used as screening tests or surrogate markers of sarcopenic obesity in this long-term pediatric leukemia survivor population, which lends weight to the importance of considering detailed body composition assessments for screening instead. Our main limitation in this analysis is our small sample size used for these calculations, which we hope to improve by extending this analysis onto a second larger cohort of similar survivors. Future prospective trials, which collect data on additional potential screening tools and functional components of sarcopenia, as well as metabolic outcomes, are warranted. And I know I have lots of time, but that's about all I have for today. So thank you very much for listening, and I'm happy to take any questions that you might have.